Anything below 5 or more than 25 is there. In that cases, this is variability. Okay. And then comes the deceleration. What is deceleration? Repetitive variables, like there is a normal reading going on and then there is something dipping going on. In that cases, if there is a dipping going on more than 3 minutes, but less than 10 minutes, in that case, is deceleration. I will describe what is one more table that you have to do. Because acceleration is usually asked. So there shouldn't be any, there should be an acceleration, but in a normal reading, there is no accelerations. Acceleration means your heart rate is getting more. You can think of that. So how do I make the concept of this one? Just think that, we're talking about the heart rate of a normal person. There should be any deceleration. If there is a long deceleration, then this is abnormal. Deceleration means like someone is going in bradycardia. Now, there should be acceleration. Why? Because with the movement, with your activities, it should be there. So if the fetus is there and he is moving around and everything is going fine, it means there should be deceleration with the movements, with their activity. So if there is no acceleration, like no tachycardia, in that case, this is abnormal. I hope that makes sense. This is just an easy way to memorize. Then describe non-stress test. In that one is baseline, variability, acceleration, and deceleration. So we already discussed this one. Reassuring BPP is basically the check 8 by 8. In that one, we have to check for the limb flexion, extension, limb movement, AFP movement, and then breathing. So you always, I think, not just me, everyone do mix up what is NST and then BPP. NST is checking for heart. Okay, like non-stress test is basically checking for their heart. BPP is basically biophysical, like everything parameters. So in those ones, we are checking for what? Limb extension, like body movement, the fluid inside, like the movements, and then the breathing. So everything. Okay, so this is basically checking for all of these things, just for your idea. So they'll put it all of them together, and there is question that can be asked where they can ask you to calculate the BPP. Okay. Then the operating characteristics we already discussed. Normal should be more than 32-week gestation, and then less than 32-week is basically having two accelerations. I discussed there should be acceleration. How much? Two of the acceleration should be normal. And then having them more than 15 BPM, lasting for more than 15 seconds and 20 minutes. And less than two acceleration is basically not good. Deceleration is bad, as you can go D. D is basically demotivated, or D or whatever is bad. Acceleration is good. There is no observed acceleration or the fetal movement in the first 20 minutes. Stimulate the fetus to see how it's going on. Then comes the biophysical profile. This one is very, 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 very important. In this one, they can give you parameters and ask you to calculate it. So ultrasound assessment of the fetus with fetal heart rate. Post-term pregnancy, decreased fetal movement, IUGR, and any of the fetal distress, you have to go for this one. What are the parameters checking for tone? They can give you, oh, there is one limb flexion and extension, or there is only limb flexion. In that case, is giving you points. Then movement, 3 discrete movements should be there. Breathing, at least one episode of breathing should be there. Then the amniotic fluid should be 2 into 2. So you have to memorize this one because it can be asked and then ask you to calculate the numbers. 8 by 10 with the normal fluid, it should be normal. Then 6 to 8 is basically stimulate and recheck and everything. Then 6 to 10, less than 6 with the normal perinatal variability, equivocal, and then recheck again in 24. And 0 to 4 is basically when the fetal is considered, you have to do the delivery. So they can ask you what is the next by giving you BPP, what is the next step that you will do. So you have to calculate the numbers, and from their numbers, you can decide what you have to do. If it's less than 4, if it's 4 or less than 4, in that cases, you have to do the delivery. Then when we are talking about counseling, about the nutrition, tell them what to eat. Mainly, we are talking about folic acid, calcium, and vitamin D. So folic acid, calcium, vitamin D, and iron tablets. Caffeine is stimulant. So in that case, is tell them that it can cause stimulation and intrauterine growth. Herbal teas can cause a lot of problems. So in that case, if some people ask for, oh, can I go for ginger tea and all that? You can tell them you can go for 2 to 3 cups. Foodborne diseases can be there. In that cases, what are those ones? Like mainly with the fish. What are the important thing? This thing. So just for your idea, it contains mercury. And then this question is also, I think, in MCC practice test, where there is chemical contamination of the food. Like female is living by some some village or something where there is a lake where she is eating fish from. They did not say that she is consuming fish, but they just give you an area or location where there is fish availability. So you can see that they are talking about fish. There is something related to it. So, and now she is can present, and what do you counsel in that female? So letting them know that don't consume fish because it contains mercury and it can cause the fetal damage. So if they are talking about any specific area where you know, or they are giving you, and because she's living in an island or she's living somewhere and now coming for a checkup, so in that case, you have to talk about the fish contamination with mercury. Then lifestyle, always talk about not to get bedridden. And some patient do like to ask about the sexual intercourse. So in that cases, you have to tell them at least avoid in the first trimester, then going for the, because it can cause spontaneous abortion, PTL and all that. Placenta previa. And then female can ask about the weight gain, how much I weight gain. So you have to check about, tell them to every time they come to, they do have to do the weight measurement. Smoking, always tell them that there is no safe limit to do the smoking. Then alcohol, there is no amount of alcohol that is safe. There is no amount of cocaine that is safe. There is no amount of cannabis that is safe. Then biophysical consideration, checking them pregnancy about mood, stress, whatever. What are the medications that can cross the pregnancy placenta and then cause damage? So ACE inhibitors, carbamazepine, chloramphenicol, lithium, misoprostol, NSAIDs, phenytoin, retinoids, sulfa drugs, tetracycline, valproate, and then warfarin. Then comes the immunization. So offering all of the immunization, especially after pregnancy. Okay. So rubella and hepatitis B and delayed postpartum. So in that cases. So usually ultrasound and MRI is safe, no X-rays, CT scans. Then comes the antepartum hemorrhage. It is an emergency. Antepartum hemorrhage is basically vaginal bleeding from 20-week to term. So if someone is having a vaginal bleeding from 20-week to term, in that case, this is called antepartum hemorrhage. Then blood show is there, placenta previa, abruption, vasa previa, cervical lesion, uterine bleeding from the bladder or the bowel. Just for your idea, most common physiological is having a cerclage or having changes, early changes of dilation. So bloody show in T3s is the most physiological etiology. So if someone can present with that one, you have to check the ultrasound, you have to do the fetal quickening, everything. And if everything came out normal, so in that cases, you can tell them that there is cervical changes going on. So reassurance, just to keep in your mind. Then comparison of placenta previa and abruptio placenta. Placenta previa is basically history of placenta previa could be there. So in that cases, always think of placenta previa. Multiparity is one of the most common increased maternal age. So with age, it is something you have to keep in your mind. If someone is talking about more than 35, either it's placenta previa or either it's a abruptio placenta. Then increased maternal age, multiple gestation, uterine tumor, fibroids can cause a lot of it, uterine scar due to previous abruption and myomectomy. And it is always painless. Then comes the abruptio placenta. It is a premature separation of the normal implanted placenta after the 20th week. Previous abruption, maternal hypertension, vascular disease, cigarette smoking, consumption, cocaine, multiparity, PPROM, and then the rapid decompression of the distended uterus, and then trauma and fibroids. So it's usually painful. Abruptio placenta could be painless, but it's usually painful. But if they are checking you in the exam, if you give you a scenario and they're looking for abruptio placenta, they will tell you it's painful. They will not put the painless, because painless is mainly placenta previa. Okay, so in exam they won't make it complicated for you. Then placenta previa, placenta implanted in the lower segment of the uterus. So we know this one. This is mainly painless, bright, and vaginal bleeding, may common in the bleeding in 30th week. So do not perform any digital vaginal exam until ruled out placenta previa. So it's one of the most important thing. And a same question can be asked where she is not having any vaginal bleeding, but she did her ultrasound. Now she is having placenta previa. In that case, is what you need to do is if she is not having any bleeding, all you have to do is reassurance, because you can tell them that with the age of the with the gestational age change, the placenta keep changing its location, so it can go in the back, but in any time if she is having any bleeding, then she has to go to emergency. So this question can be asked with bleeding, without bleeding. In the ultrasound is placenta previa, how will you do or what will you do in that case? So it can be asked. This is basically a reassurance case. And if there is a bleeding, then in that case, you have to look for other things. Do not perform any vaginal exam until placenta previa has been ruled out by ultrasound. So if a patient is presenting in an emergency with bleeding, usually we go for the ultrasound right away. Uterus is soft and non-tender, then presenting fetal part high and displaced, then fetal heart rate is usually normal, then shock and anemia could be cause of the bleed. Complications like fetus is basically prematurity, can die, malpresentation, PPROM, like all of those ones. Then maternal, obviously mother is losing blood, all the shock or whatever those symptoms. So then the investigation is transvaginal ultrasound is the most accurate, then transabdominal ultrasound, a diagnostic procedure checking for diagnosing the placenta previa. Then spontaneous resolution is likely with the increasing uterine distension if the placenta covers the internal os by less than 20 millimeter. Transvaginal ultrasound should be repeated in T3s at continuous change in the placenta location is likely. So in that case, you just have to tell them like it's mainly the reassurance if there is no bleeding. Goal, keep pregnancy intrauterine until the risk is continuing the pregnancy is good. Then the stabilize and the monitor, you have to monitor like in obstetrics. After stabilizing the mother or whatever, don't forget about the baby as well. You have to stabilize the baby as well. But first thing first, always stabilize the mother. Large bore IV line, oxygen, hypotension, then monitoring vitals, urine output, blood, then the blood workup, CBC, INR, PTT, fibrinogen, all that. Then external fetal monitoring, checking for the NST, BPP, all of these ones. Ultrasound assessment could be done. Then the ROGAM, if the mother is Rh negative, then follow cytometry and clear bed key checking for all of that. Less than 37-week gestational age and minimal bleeding, expected management, admit to the patient. This says minimal bleeding. I was talking about no bleeding. No bleeding, reassurance. Minimal bleeding, admit hospital, limit activities, corticosteroid, maybe it's the time to do the delivery. If more than 37, in that case, is going for delivery with the cesarean section. So just to let you know, in placenta previa and placental abruption, we both go for the cesarean section, not the vaginal delivery. It can be asked in the scenario too. Then the placental abruption, the partial or the total placental detachment that is premature and caused by bleeding at the residual of the interface, total versus partial external bleeding, then the internal concealed and then occult, most or mixed. Presentation is usually painful, so they will give you painful when they are talking about Russian placenta. Placental abruption is the most common cause of, DIC in pregnancy. Then the pain and sudden onset, constant, localized to lower back and uterus, shock, fetal distress, and coagulopathy could be there. Fetal complications, obviously, fetus can die and prematurity, hypoxia. When it comes to mother, obviously, she will have failure, shock, hemorrhage, renal problems. Then one of the most common presentation is basically having a Sheehan syndrome, like prematurity necrosis. Then that is one of the most common that can present. Then amniotic fluid ambulance could be there. So the most important that can be asked is the Sheehan syndrome. So then comes it's a clinical diagnosis. Don't go for ultrasound or wait for ultrasound. As you can see, the placenta previa, we did the ultrasound. But in this one, we are going for the clinical diagnosis. Ultrasound not sensitive for diagnosing. Maternal stabilization, always stabilize the mother. Then don't forget about the fetus as well. External fetal monitoring, blood products on hand, ROGAM. Abruption without the fetal maternal compromise less than 37 week, more than 37 week. When we are talking about less than 37 week, use the serial hematocrit to assess the concealed bleeding. More than 37, stabilize and deliver. Abruption with the fetal and maternal compromise, hydrate and restore the blood loss, correct the coagulation defect if present, vaginal delivery, cesarean delivery if that one. So as you see in the placenta previa, we go for cesarean delivery. Even in the with this abruption placenta, if there is a chances, then we can go for vaginal delivery. But then we can go for cesarean section if you want to see the fetus or whatever is going on. Then the vasa previa, we'll do the vasa previa too, okay? Then unprotected fetal vessels pass over the cervical os and associated with the velamentous insertion of the cord to the membrane. So it is also painless, vaginal bleeding, and the fetal distress is there, 50% prenatal mortality, and then in diagnose the antenatally on the ultrasound. So APT test is done, then the right strain test is done. Usually we go for APT and then this is more than enough, but right test can be done as well. Then we have to plan the cesarean delivery or if the bleeding emergency C-section. So from an obstetrical complication, we'll start from here on Tuesday.